Yeah, so that was a particularly interesting study that we did, because what we tried to do is collect a large cohort of patients that had one of the classic high-risk genetics, and we did it over a very long period of time. So we were able to show that with increasing levels of risk stratification, i.e. treating these patients with more intensive chemotherapy, they can, most of them had an improved outcome with that extra chemotherapy. So that was really encouraging. The one group that kind of didn't improve as much as others were the group that had either near-haploidy, so that's less than 30 chromosomes, or low-hypodiploidy, 30 to 39 chromosomes. So this is actually a very small number of children with acute lymphoblastic leukemia. And it's interesting to note that in some of the other abstracts that have been presented here, and some of the recent papers where they've introduced Blinatumomab therapy, that is still one of the subtypes that seems to have the most resistance to both chemotherapy and immunotherapy. This is a big issue in adult ALL, where low hypodiploidy accounts for about 10 to 15% of older adults. So that's going to be a real sticking point, because Blinatumomab is the major change in the therapy of ALL over the past few years. And if that group really is resistant to Blinatumomab therapy, then that is the one group that is going to need additional attention.